beneficial for bone health. So what is osteoporosis? I'll give the NIH definition. They define it as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. Basically, the bones have become weak and brittle, and that happens when we lose too much bone or we don't make enough bone or both. I've listed the major risk factors for osteoporosis. Age. So as we age, our bone density will tend to decline and our bone remodeling processes become less efficient. Hormone decline. In menopause, women will have declines in estrogen, progesterone, and testosterone, and men can see decline in their testosterone levels. Nutritional deficiencies like calcium and vitamin D and other nutrients, physical inactivity and lack of weight bearing, having a family history of osteopenia or osteoporosis, smoking, and excessive alcohol intake will both reduce bone density. And then I've listed other medical conditions, and here that would include things like rheumatoid arthritis and other autoimmune diseases, many of the gut disorders, so Crohn's disease, ulcerative colitis. These conditions will cause bone loss because of chronic inflammation and malabsorption. Also, celiac disease, as well as non-celiac gluten sensitivity because of impairment of nutrient absorption. Irritable bowel syndrome is associated with an increased risk of osteoporotic fractures, and that's due to intestinal inflammation. GERD or acid reflux disease, especially if someone is using acid blocking medications, will increase the risk of osteoporosis. Liver diseases, and also anyone who's had a history of gastrointestinal surgeries or a resection of part of their intestinal tract. And then some hormonal disorders that will lead to osteoporosis, hyperthyroidism and hyperparathyroidism. And then I've also listed here certain medications, so steroid medications, some anti-seizure medications, some antidepressant medications, acid blocking medications, and even some cancer treatments can lead to bone loss. And what are some of the things that we can do to prevent osteopenia and osteoporosis? So a bone healthy diet with adequate protein and the right nutrients, supplements, physical activity and exercise, controlling glucose and blood sugar and reversing insulin resistance, reducing inflammation. So inflammation anywhere in the body is a well-known cause of bone loss. So inflammation in our skin, in our joints, in our intestinal tract, in our mouth, really inflammation anywhere in the body can contribute. We also want to optimize gut health. And we want to avoid and remove our exposure to toxins. I'm just going to get sidetracked here for a second here and show you this article from 2021, the journal Integrative Medicine. Environmental toxins are a major cause of bone loss. So this shows cadmium, lead, mercury, chemicals such as pesticides, phthalates, bisphenols, or BPA disrupt bone metabolism in many ways. Body levels of these toxins directly correlate in a dose-dependent manner with risk of fracture and osteoporosis. So toxins. Another article, 2023, International Journal of Molecular Sciences. Endocrine disruptor induced bone damage due to hormone dysregulation. This study highlights the harmful effects of environmental toxicants on bone formation. So talking about chemicals from pesticides, plastics, our personal care products, household products, many of these environmental toxins will contribute to bone loss. And then where we don't smoke, avoid excessive alcohol, don't drink soda. There are ingredients in soda that will cause bone loss. And then we also want to reduce our stress and get plenty of sleep because excessive stress and inadequate sleep are big contributors of inflammation, and inflammation will lead to bone loss. This article from 2019 in the journal Menopause, the association between soft drink consumption and osteoporotic fractures among postmenopausal women. Shows consuming more than 2 servings of soft drinks per day on average showed potential associations with higher risk of hip fracture among postmenopausal women. And then bioidentical hormone therapy as another approach for prevention of osteopenia and osteoporosis. So, what are bioidentical hormones? Bioidentical hormones are natural plant-based hormones that are used for hormone replacement therapy for hormonal imbalances, perimenopause, menopause, and testosterone deficiency. These hormones are created to be identical to our own hormones, and they are biochemically indistinguishable from human estrogen, progesterone, and testosterone. So they exactly mimic our own hormones. These hormones can be used to ease symptoms related to hormone imbalances and deficiencies, including osteopenia and osteoporosis. How are bioidentical hormones different from traditional hormone therapy? Well, traditional hormones are synthetic hormones. They're not identical to our own hormones. They tend to cause more unwanted side effects because they're not the same as our hormones. And for example, synthetic estrogen is actually horse estrogen. It goes by the brand name Premarin, which comes from pregnant mare's urine, Premarin. It also goes by the name conjugated equine estrogen, or CEE. Synthetic progesterones aren't even progesterones at all. They're actually called progestins, and they go by the brand name Provera or medroxyprogesterone acetate, or MPA. And these progestins are chemicals synthesized to mimic progesterone, but they're not progesterone. And so, for that reason, they also tend to cause unwanted side effects. BHRT is completely customizable so that you get what you need, no more or no less. And it's not like synthetic hormones where there's only a few doses to choose from, where every woman has to choose from one or two different doses. And that would be like saying every woman has to wear either a size 6 or a size 11 shoe, and that just doesn't work. But with BHRT, it can be completely customized to any dose that a woman needs. The other benefit is that they're easily monitored in the blood. We can measure blood levels of these hormones because they're natural. You can't monitor synthetic hormones in the blood because they're chemicals that don't belong in our blood, so there's no blood test for them. BHRT is also transdermal, so they're applied topically in the form of a cream, typically. Oral estrogens increase side effects. So Premarin, which is the traditional synthetic estrogen, is taken orally, and then BHRT can't be patented because they come from natural substances. The pharmaceutical companies can't patent them, and so they're not promoting them because there's no money to be made in them. So I just wanted to show the differences. So Premarin is the synthetic horse estrogen. Estradiol is human estrogen. Progesterone is the human progesterone, and then medroxyprogesterone acetate, or Provera, is the synthetic progesterone, and then a molecule of human testosterone, and then testosterone cypionate is synthetic testosterone. So you can clearly see there are differences between the synthetic versions and the human versions. And if you're going to take hormone therapy, you're going to want to take something that's identical to our own natural hormones. So women might consider bioidentical hormone therapy if they're having irregular periods, hot flashes, night sweats, sleep disturbances, mood swings, fatigue, midsection weight gain, decreased libido or orgasm, vaginal dryness, brain fog, joint stiffness, and osteopenia. Men might consider testosterone therapy if they're having fatigue or low motivation, depression, decreased libido, erectile dysfunction, muscle loss, memory loss, or bone loss. And men and women don't have to have any of these symptoms to consider hormone therapy, because hormone therapy really slows the aging process. It just makes you feel better, and they can be used to prevent osteopenia and osteoporosis. So why isn't everyone taking bioidentical hormone therapy? Well, in the 1960s, 70s, 80s, and 90s, everyone was, and that includes synthetic as well as bioidentical. All women were being prescribed hormone therapy when they entered perimenopause and menopause. Primary care doctors, OBGYNs, were always prescribing these patients from the 1960s to the 1990s. All women were put on this kind of therapy, and not being prescribed this type of therapy or hormones would be considered bad medicine at that time. But all of that changed overnight in July of 2002. And that's when the results of the Women's Health Initiative study came out. And that was a study that started in 1996, and it was stopped abruptly before it was completed, only after 6 years, because they were finding in that study that women put on hormone replacement therapy were getting a higher risk of breast cancer, heart attacks, and strokes. And so overnight, all doctors, primary care doctors, OBGYNs stopped prescribing hormone therapy to anybody, and all women stopped taking their hormones because everyone was afraid and confused. Everyone was terrified. And it got enormous media coverage by the news. And the truth is that since then, so many articles, so much literature has come out showing that the results of that study were false, that the study was so poorly done. Um, the problem is that the news is not reporting that hormones are safe and good for you because it doesn't bring shock and awe. It doesn't bring fear. It doesn't make big news. And so the news isn't reporting it. And the other problem, too, is that many doctors aren't staying up to date on the latest research on hormones. And so everyone is still afraid of the hormones. But what I want to show you is that since then, since that 2002 study showing those results, many articles have come out. Many research studies have come out showing that the results were false and that study was very poorly done. This article from 2017 from the Journal of the American Medical Association, JAMA, actually took the exact same women from that Women's Health Initiative study, the same participants from that initial study, and followed them for 18 years. So after the study was stopped, they continued to track them for another 18 years. And what they found among the 27,347 in that original study, that hormone therapy with conjugated equine estrogen and medroxyprogesterone acetate for a median of 5.6 years, or conjugated equine estrogen alone for a median of 7.2 years, was not associated with risk of all-cause cardiovascular or cancer mortality during the cumulative follow-up of 18 years. So they continued to follow those women after that study was stopped and found that women were not dying earlier. They weren't having more cancer or cardiovascular disease than the women that were on the placebo in that study. In fact, they actually found that the quality of life, prevention of osteoporosis, prevention of heart disease, Alzheimer's disease, increasing sexual satisfaction, eliminating hot flashes and night sweats in the women who were on hormones compared to the women that were on placebo. The women on hormones actually did better. They also found in that study that hormone replacement therapy reduced hip and vertebral fracture risk by 34% and osteoporotic fractures by 24%. And the major flaws of that Women's Health Initiative study, one problem with it was that they only allowed older women to participate in the study. So all of the women in the study were at least 10 years past their menopause. And the reason that they did that, the reason that they didn't choose newly menopausal women for the study was because the only way that they could keep the women from knowing if they were on the hormones or the placebo was that none of the women could be experiencing any hot flashes or night sweats. Because if they got the hormones, their hot flashes and night sweats would go away. If they got the placebo, they wouldn't go away. So they couldn't involve any women in the study that were in the early stages of menopause. They could only include women that were at least 10 years past their menopause. And so these were older women. They were sicker. They already had heart disease or strokes. They weren't in good health. And the other problem with the study was that they didn't include bioidentical hormones in the study. They only included Premarin and Provera, or conjugated equine estrogen and medroxyprogesterone acetate. And bioidentical hormones behave completely differently than the synthetic hormones, and they have a decades-long track record of safety. But when they found that Premarin and Provera were causing problems, they labeled all hormones as bad. And so all types of hormones were stopped in 2002, unfortunately, even though only these two were the ones included in the study. And then here's another study from 2014 in the journal Steroid Biochemistry and Molecular Biology, the Women's Health Initiative trial and related studies 10 years later. It revealed that starting hormone therapy in postmenopausal women less than 10 years from their last menstrual period appears to have less risk. And, this is, before 2002, doctors prescribed hormones to women that were newly menopausal. They were just entering the transition. They didn't wait 10 years later when they've already been, they've already suffered with all of their symptoms. They initiated hormones early. Data supporting the use of hormone therapy administered to postmenopausal women showing it to have more benefit than risk for symptom control, prevention of bone mineral loss and fracture, and improvement of the metabolic profile in women who began hormone therapy when they were less than 60 years of age and had their last menstrual period less than 10 years previous. Confirmation that hormone therapy for most newly menopausal women is safe and effective. Another study from 2005, fertility, sterility. The therapeutic regimens resulted in prevention of atherosclerosis and reductions in coronary artery disease mortality. It is our conclusion that the Women's Health Initiative hormonal replacement study had major design flaws that led to adverse conclusions about the positive effects of hormone therapy when initiated appropriately in a population of younger, more recently menopausal women, has promised to yield a more favorable risk-benefit outcome. From 2006, nuclear receptor signaling. In contrast to the conclusions reached by the Women's Health Initiative and the National Heart, Lung, Blood Institute, I conclude that treatment of postmenopausal women with estrogen and progesterone, or Prempro, does not increase the risk of cardiovascular disease, invasive breast cancer, stroke, or venous thromboembolism. From 2003, the journal Climacteric Hormone Replacement Therapy in the Post-Women's Health Initiative Era. The target population used in the Women's Health Initiative is not representative of the target population for whom menopausal hormone therapy is normally considered. Since their publication, the relevance of the Women's Health Initiative study results for everyday clinical practice has been the subject of controversy. The Women's Health Initiative targeted a group of women who were much older than those normally treated and who had numerous other risk factors. These were not women for whom a practicing clinician would think about initiating hormone therapy with the regimen that was used. 0.625 milligrams of conjugated equine estrogens plus 2.5 milligrams of medroxyprogesterone acetate, those are high doses, would not seem appropriate for any indication. Focusing on data taken out of context and without reference to subject profiles, the media created an emotive wave of uncertainty for patients and physicians. It's clear that hormone therapy is effective for postmenopausal symptoms and osteoporosis prevention. And then this is a very recent study. This just came out in December 2023 in the journal Menopause. Get this out of the way. More recently, the Women's Health Initiative publications acknowledge hormone therapy as the most effective treatment for managing menopausal vasomotor symptoms, and that conjugated equine estrogen alone reduces the risk of breast cancer by 23% while reducing breast cancer death by 40%. And then here, I didn't highlight this, but the sole remaining concern is a small increase in breast cancer incidence with conjugated equine estrogen and medroxyprogesterone acetate together. But remember, these aren't the bioidentical, these aren't the natural hormones, these are the synthetic hormones. But a small increase, 1 per 1,000 women, but no increased risk of breast cancer mortality. Let's see, and women's health findings have reduced the incidence of breast cancer in the United States. A generation of women has been deprived of hormone therapy largely as a result of this widely publicized misinterpretation of the data. So one study that Women's Health Initiative 2002 results, one study showing those poor outcomes, but multiple studies reversing the findings of that one study. And then what is the evidence? I wanted to share the evidence that hormone therapy is beneficial for bone health. So 2022 in the journal Climacteric, hormone therapy for postmenopausal osteoporosis management. This study reviewed evidence from randomized controlled trials, systematic reviews, and meta-analysis, and summarized high-quality evidence on the efficacy and safety of menopausal hormone therapy in management of postmenopausal osteoporosis. 2021, Best Practice Research Clinical Endocrinology and Metabolism, menopausal hormone therapy for the management of osteoporosis. See this here. Estrogen deficiency leads to rapid bone loss, which is maximal within the first 2 to 3 years after the menopause transition and can be prevented by menopause hormone therapy. Not only menopause hormone therapy prevents bone loss and the degradation of the bone microarchitecture, but it significantly reduces the risk of fracture at all bone sites by 20 to 40%. It's the only anti-osteoporotic therapy that has a proven efficacy regardless of basal level of risk, even in low-risk women for fracture. Over the last years, subsequent reanalysis of the Women's Health Initiative and further trials have challenged the initial conclusions of the Women's Health Initiative. It's now clear that the individual benefit-risk balance of menopausal hormone therapy is dependent on the individual risk profile in each woman, as well as whether estrogen is opposed or unopposed, the type of estrogens and progestogens, or doses and routes of administration. In the absence of contraindication, use of menopausal hormone therapy should be considered as a first option for the maintenance of bone health in those women where specific bone active medications are not warranted. 2018, Osteoporosis International, Estrogen Therapy for Osteoporosis in the Modern Era. Menopause predisposes women to osteoporosis due to declining estrogen levels. This results in a decrease in bone mineral density and an increase in fractures. The Women's Health Initiative randomized controlled trial first proved hormonal therapy reduces the incidence of all osteoporosis-related fractures in postmenopausal women. However, the study concluded that the adverse effects outweighed the potential benefits, leading to a significant decrease in hormone therapy used for postmenopausal women or symptoms. Subsequent studies have challenged these initial conclusions and have shown significant efficacy of hormone therapy in various doses, durations, regimens, and routes of administration. These studies support that hormone therapy improves bone mineral density and reduces fracture risk in women with and without osteoporosis. The studies suggest that low dose and transdermal hormone therapy are less likely associated with the adverse effects of breast cancer, endometrial hyperplasia, coronary artery disease, and venous thromboembolism or blood clot, previously observed in standard dose oral hormone therapy regimen. So they're saying here that transdermal or topical is safer than oral hormones. We propose that hormone therapy should be considered for the primary prevention and treatment of osteoporosis in appropriate candidates. Hormone therapy should be individualized, and the once lowest dose for shortest period of time concept should no longer be used. 2014 Journal Steroid Biochemistry and Molecular Biology, Prevention and Treatment of Postmenopausal Osteoporosis. In the beginning, that is from the 1960s, when a link between menopause and osteoporosis was first identified, estrogen treatment was the standard for preventing bone loss. This continued until the Women's Health Initiative study in 2001 that published data on 6 years of treatment with hormone therapy that showed an increase in heart attacks and breast cancer. In later analyses, the Women's Health Initiative study showed that estrogen reduced fractures and actually prevented heart attacks in the 50 to 60-year-old age group. And then the 2021 International Journal of Molecular Sciences. So management of osteoporosis in men. I wanted to include men in this presentation too. Hypogonadal patients, so that it's men with testosterone deficiency, may be treated with testosterone replacement therapy. 2022 Archives Endocrinology Metabolism, male osteoporosis in men with symptomatic hypogonadism, testosterone replacement, if indicated, can improve bone mineral density. And then 2021 Journal of Clinical Medicine, testosterone and bone health in men. Testosterone replacement therapy should be considered as one of the treatment options to improve hypogonadal symptoms and bone mineral density simultaneously in symptomatic hypogonadal men with osteopenia. Okay, so how do hormones improve bone density? First, we'll talk about the osteoblasts and the osteoclasts. So the osteoblasts are the cells that build new bone. They are responsible for bone formation and remodeling. They're important for healing damaged or broken bone. So I like to call them the builders. The osteoclasts are the cells that dissolve and break down bone tissue. They're responsible for reabsorption of old damaged bone. So I like to call them the demo guys. The osteocytes are the cells that coordinate the activity of the osteoblast and osteoclast. So they're the contractors. So estrogen works on the osteoclasts by inhibiting osteoclast activity, preventing excessive bone resorption. They promote osteoclast apoptosis, which means programmed cell death. So it limits the lifespan of the osteoclasts. So it controls the number of active osteoclasts in the bone tissue. Progesterone promotes osteoblast activity, stimulating bone formation, and also stimulates the differentiation of osteoblasts into mature osteoblasts. And then testosterone promotes osteoblast activity, stimulating bone formation. So all of the hormones play a role. Estrogen is definitely the hardest working one. And then I wanted to talk about the DEXA scan. So the DEXA scan is our way of measuring bone mineral density. It's not our only way of measuring bone quality, but it's the most commonly used. And the DEXA scan gives us a T-score, which is a number that compares your bone density to that of a healthy 30-year-old. A T-score between -1 or greater is considered normal. Between -1 to -2.5 is osteopenia, and between -2.5 or less is considered osteoporosis. So I wanted to share some mini case studies, and I call them mini because the information that I can give you is limited. I was asked by Nico and Jason to give this presentation when I was in between practices. I had left my previous practice and I was preparing to start my new practice. So I wasn't able to actually meet with these women to discuss, what they were eating, how they were exercising, what supplements they were taking. So I wasn't able to get that type of information from them. But I did have access to bone density, DEXA scans, and I had access to their medication, so I could see that they were taking bioidentical hormones and not any of the osteoporosis drugs or the medications for osteoporosis. And so what I wanted to show you in this case, this is a 72-year-old woman. She's been on bioidentical hormones since 2017. And so in 2015, you see her T-scores. So in the spine, -3.4, -2.8 in the total hip, -2.8 in the femoral neck, and then -3.6 in the forearm. And, this first DEXA scan was probably when she was around 65, because that's when most people are being recommended DEXA scan. That's when most insurance companies are recommending the DEXA scan. But you see, waiting till someone's 65 for their first DEXA scan, and she was already in significant osteoporosis by then. So ideally, we want women to be getting their bone densities in their 50s, closer to the onset of their menopause. But she already had significant osteoporosis by the time she had her first DEXA scan. And so she started hormones in 2017. And then by 2018, you see the improvement to -3.1 in the spine. And then in 2020 to -2.6, and then in 2022 to -2.4. So from osteoporosis to osteopenia by 2022. And then in the hip from negative 2.8 to negative 2.6, negative 2.5, and then negative 2.4. So now here as well, osteopenia. And then from negative 2.8, stayed at negative 2.8. She had a decrease here. I don't know why that happened, but a decline in her bone density here, but then an improvement again in 2022 to negative 2.3. So you see all of these went from osteoporosis to osteopenia. And then in the forearm, negative 3.6, negative 3.2, negative 2.9, and then in 2022, negative 2.7. So still osteoporosis in the forearm, but all of these have significantly improved. And it says here, no significant bone loss was observed. Another case, this is a 76-year-old woman. She started hormones in 2019. So 72-ish when she started hormone therapy. And in 2015, let's see, she had osteoporosis here in 2015. It got worse in 2018. She started the hormones in 2019. Oh, here. So she's worse in 2019 here. And that's when she started the hormones. And then it improved in 2021. And then again, you see here, she was getting worse, getting worse, getting worse, started the hormones. And then you see the improvement here in 2021. And then as well in the femoral neck, all of these are getting worse, but improved after starting hormone therapy. And then this in her forearm, she isn't improving in her forearm. She is still having some bone loss. But the change from negative 4.3 to negative 4.5 is not considered significant. It's a small change. And so they're saying no significant bone loss was observed here, but definitely some improvement in the other areas. And then this is a 69-year-old woman. She's on hormone therapy. I can't see the top of the slide here. Let's see, how can I get that? All right, I can't see the top of the slide because of the screen sharing. Okay, so negative 0.6, positive 0.2, 0.3, 0.3. Okay, so you see the improvement from negative 1.2 to negative 0.8. This declined, but this came back up again. And then from negative 1.3, got worse in 2019, but improved in 2021 and improved further in 2023. And then only one previous study in the forum here in negative 1.5, improved to negative 1.2, and improved to negative 1.0. A 58-year-old female on hormones since 2021. So she started younger. She started 56 when she started the hormone therapy, but her first DEXA at age 55 in 2020, she already had osteoporosis. So checking your first DEXA at a younger age is definitely worthwhile, even if the insurance doesn't cover it, because you see she already has osteoporosis. And so then she started the hormones following this report and improved to negative 2.7, improved from negative 2.2 to negative 1.7, and then from negative 2.7 to negative 2.6. And this is an 80-year-old woman. She's been on BHRT since 2016. I don't have reports of her previous DEXA scans, but you see even after age 77, she's still improving. This is a slight decrease here, very slight decrease. This is a slight increase, and this is an increase in bone density. But you see no significant bone loss was observed. So she's still improving her bone density even at age 80. A 71-year-old woman since on BHRT since 2016, from negative 0.1 to positive 0.2, negative 1.6 to negative 1.2. So you see these are improved. This is a slight decrease here in bone density, but you see no significant bone loss was observed because this is a very slight decrease. Okay, so the efficacy of bioidentical hormones, there are several factors. So, your baseline bone density is going to make a difference. So, if we're able to start hormones before the bone density has had a chance to decline too far, bioidentical hormones are going to be more effective. Also, someone's overall health. So, If a person has a lot of inflammation, or if they're not eating a healthy diet, or if they're not physically active, that will also impact the how effective the bioidentical hormones are. And age, earlier is better. So starting the bioidentical hormone therapy closer to the onset of menopause before developing osteopenia and osteoporosis is going to make them more effective, and longer duration is better. So, in summary, in addition to diet, nutrition, and lifestyle modifications, bioidentical hormone therapy is a safe and effective way to treat osteopenia and to prevent osteopenia and osteoporosis. It's important to discuss your individual risks with your healthcare provider. Okay, so let me stop sharing. Okay, so we'll take some questions. Let me see if I can. First question was, so breast cancer diagnosis 4 years ago. Did I use hormone? Left an impression. I'm not sure what the question. Is there any data regarding family history of breast cancer and taking BHRT? Okay, so having a family history, and especially if it's BRCA positive, so there's that's going to increases someone's baseline risk for breast cancer if they have a gene, a BRCA gene. Um, But if a woman doesn't have the BRCA gene positivity, it's important to know that many women get breast cancer even without a family history of breast cancer, even without taking hormone replacement therapy. So you'll see many women getting breast cancer who've never taken hormone therapy a day in their life. They never even took birth control pills ever. And you'll see some of these women getting breast cancer because there's so many other causes of breast cancer. So pesticides and BPA and other endocrine disruptors. And so being on hormone therapy doesn't necessarily increase a woman's risk of breast cancer, but many, many women, even women who've never taken hormones, have a risk of getting breast, because all women can get breast cancer even without hormones. Is there a dosage level? Let's see. Is there a dosage level of BHRT that is too much and could cause side effects? So when you're taking hormone replacement therapy, we always want to give the lowest possible dose, the lowest necessary dose to get the benefits of it, because we want the hormones to um, maintain our brain function, maintain our bone density, maintain our health without taking more than is needed. And that's why bioidentical hormones are so useful, because you can monitor the levels to make sure that you're not getting too little and not getting too much. And so it takes the guesswork out of it. But with the synthetic hormones, we're not able to monitor levels, but we can do that with hormone therapy so that we can make sure that you're not getting more than you need. But less is better. Let's see. I'm gonna try to take these in order. Is there a cutoff age for taking BHRT in the person who doesn't? There isn't. You can take BHRT for as long as you want, up to any age. There's no cutoff. The BRCA gene was negative on the sibling with breast cancer. So that doesn't increase a woman's risk for breast cancer any more than anyone else, if she doesn't have the gene for it. If I am on hormone suppressant like letrozole, wouldn't this be contraindicated? So if you're taking letrozole, which is an estrogen blocker, then it wouldn't make sense to take hormone therapy. So if your doctor, your oncologist is prescribing letrozole to lower your estrogen levels, then you wouldn't want to be taking hormone therapy. I got that one. What levels of hormones in the blood are ideal? Well, it depends on if we're talking about estrogen, progesterone, and testosterone. There's going to be different levels. Um, We want levels that are going to be beneficial enough, for example, enough estrogen to keep the bone strong, enough estrogen to keep the memory function. Um, an estradiol level, I like to see between 50 and 80 on a blood test. Um, Testosterone, would be, you'll see the normal range for free testosterone, free and total testosterone. So as long as we're maintaining the testosterone within the normal range for a woman. Can you take BHRT if you have fibroids? So, fibroids is actually a hormone deficiency causing those fibroids, and it's usually from an estrogen dominant state. So, a woman that has um, relatively higher levels of estrogen and lower levels of progesterone. So, progesterone can actually help prevent fibroids, it can help shrink fibroids as long as the fibroids haven't gotten too large. But yes, definitely progesterone can be helpful for fibroids. My functional doctor put me on raloxifene. I have SIBO. Your opinion? So raloxifene for bone density, and then I'm not quite understanding the relationship with SIBO, which is small intestinal bacterial overgrowth. So, Shahira, I don't really understand your question. I have Hashimoto thyroiditis, hypothyroid. My last period was 10 to 12 years ago. I'm 59 and I have osteopenia. I'm both years. No, it's not too late. Obviously it's more effective the earlier you start it, but it's never too late. I mean, can someone start taking BHRT? Yes, after 70, and a woman can start taking BHRT. It's never too late. You're welcome, Mary. I hope that was helpful. My doctor suggested I start taking alendronate. Okay, so that is the generic Fosamax to increase bone density. I don't have my bone density numbers. I'm concerned with all this side. Yeah, I know where you're coming from, Suzanne. So you haven't started taking it. How is different? So alendronate, Fosamax, what it does is it actually stops the osteoclast activity completely. So we actually need some osteoclast activity and osteoblast activity. So remember, the osteoclasts break down bone and the osteoblast build bone. And both the osteoclast and osteoblast have to be working together because we don't want to keep all of that old bone. We want to break down that old bone. And what Fosamax does is it stops the osteoclast activity. So you build up all this old bone and so your bone actually becomes brittle. And so for that reason, they want you to stop taking Fosamax after taking it for 5 years because your bones actually become more brittle with Fosamax. Whereas bioidentical hormone therapy, it doesn't stop osteoclast activity, but it limits osteoclast activity. So you have healthier bone with the bioidentical hormones compared with the Fosamax, which would give you hard, brittle bones that are more likely to fracture after long-term use of the alendronate or Fosamax. 72 years and have osteoporosis. Is it too? Nope, it's not too late. It's not. What is the ingredient in soda? Oh, it's a phosphorus substance. Yeah, definitely. And all those articles that I showed you, those are all PubMed articles that you can easily look on PubMed. And I didn't even give you all of the articles. If I gave you all the articles, we'd be here all day. But there's so many articles similar to what I've posted on this slideshow, um, and you can read all of those yourself. Is BH? No, good question. Good question. BHRT is not covered by insurance, but generally costs about $40 per month, depending on which pharmacy you go to. They're made by compounding pharmacies. You won't get them at your Walgreens or your CVS. Um, they're made by compounding pharmacies, which are located all over the valley, but they're not covered by insurance and they're not terribly expensive, around, like I said, $40 per month. Could I be on BHRT and raloxifene? Did get breast cancer, she claims from her. I wonder what type of HRT your mom was on, Shahira, if she was on Premarin, Provera. Um, I don't know if there's any studies using BHRT and raloxifene together. So I really can't comment on that for you, Shahira. My 95-year-old mom is going the osteoporosis prescription. I can't change that. Which of the osteoporosis prescription is the least of the evils? Oh, okay. Well, a lot of that depends on how severe her osteoporosis is. And the different osteoporosis medications have different functions. So I mentioned Fosamax, which stops osteoclast activity. It doesn't do anything for osteoblast, but it just halts the osteoclast activity. Whereas, Prolia, um, Forteo, some of the other ones, they have different functions, and I like those better. So Prolia I definitely like that better than the Fosamax and the Benevas. Um, and then Forteo, but downside with the Forteo is it's a daily injection. Is it riskier for someone more than 10 years postmenopause to start PHRT? Is it? No, it's not. Is it not recommend for? No, a breast cancer survivor can take bioidentical hormone therapy. You'd want to know if it was estrogen receptor positive or not, or progesterone receptor positive. But definitely can be very safe in postmenopause and in breast cancer survivors. And there are many breast cancer survivors that take bioidentical hormone therapy safely. What are the side effects? Where do I get started? Where do I go to get started on birthday? I am taking patients. Um, so what are the side effects of bioidentical hormones? So really, the side effects are going to be from um, if your dose isn't where it should be. And that's why having the blood test to tell you if the dose is too high or too low. But for example, if you have too much estrogen in your BHRT, then your breasts might feel sore, kind of like, they might have used to feel before your period. They get kind of uncomfortable, but that would be if your estrogen dose is too high, and that can be easily reduced. Um, Another thing, if a woman is on a too high of an estrogen dose, and if she still has a uterus, she could start spotting. She could start bleeding again. But it's not dangerous. It's not scary. If that happens, you just need a lower dose of estrogen. Progesterone is the calming, relaxing hormone. It helps women sleep. And so if you're on too much progesterone, it might just make you too tired during the day. So you're going to want to back off on the dose or lower it. But it's calming. It helps reduce anxiety. It helps you relax, helps you sleep. Um, Too much testosterone, and again, you have those blood tests to tell you if you're getting too much. But too much might make you feel kind of, hyper, kind of too much energy, kind of over caffeinated or something. Maybe some acne, that kind of thing. But, if you have symptoms like that, you can reduce the dose, and it's all reversible. Um, is the harmful ingredient in soda also found in other fizzy drinks? So fizzy drinks may just be fizzy because of the carbonation. It's not the carbonation that causes the bone loss. It's the phosphorus ingredients, and that's mostly in the dark colas. Like Pepsi and Coke. The darker colored colas have more of that ingredient. If it's not covered by insurance, how do I get started on them? So you're going to want to see a functional medicine doctor or a provider. Sometimes naturopaths prescribe them. Um, and so, you'll have the doctor do blood testing to check your levels and then prescribe them for you. And then, like I said, the compounding pharmacies is where those are made. What do you think about Oh, good question. Therapy. I have been on that for 14 years, but tried BHRT gels for a year and all my levels. Okay, so pellet therapy. Um, for those that don't know, these are hormone pellets, maybe the size of a small grain of rice that are inserted into your behind. These are estrogen and testosterone pellets. They don't make them for progesterone, so you'd have to take progesterone separately. But pellet therapy, What I don't like about them is that they don't give you hormones in a natural physiologic way because you get pellets inserted every 3 to 4 months, maybe 5 months, depending on how fast you metabolize them. And so you're getting high doses of hormones once every 3 to 4 months. And so what you see is this, big sharp rise and then slowly dropping, and then another sharp rise when you get your next pellets, and then it slowly drops. And so you can have this ups and downs, like a kind of a roller coaster effect, where you're getting hormones once every 3 or 4 months, and then you feel them wearing off, and then you start dragging, your energy levels go down, you're not sleeping as well. And then you get your pellets and you get that, sharp rise again. And that's just not the way women or men naturally make hormones. We don't make hormones every 3 to 4 months. We make hormones every day. And so what happens with the pellet therapy, you feel those ups and downs, so the roller coaster effect, but also oftentimes the doses, the levels of hormones can get very, very high. And once those pellets are in, you can't pull them out. You can't remove them. And so if you're having side effects because the levels are so high, there's nothing you can do but wait for them to wear off. And so what I see a lot of times, women come to me who've been on pellets and their levels have gotten so high that their hair's falling out and they're having other side effects from it. And they want to switch over to the creams because you have more natural, consistent levels. Because with the cream, you're applying it daily, and so you have more consistent levels of your hormone therapies without the sharp rises and falls. But it's also much more easily to adjust a cream than pellets, which you can't adjust at all until those pellets wear off. I hope that answered your question, Shepard. And then if your levels crashed, like I said, the levels can get very high with the pellets because the only way that they can get those pellets to last 3 or 4 months is to give high doses. They have to give those high doses so that they will last 3 or 4 months. Because if they give you normal lower doses, they won't last long enough. And then you'd have to keep going in and getting those pellets inserted. And so when you switched from pellets to the gels, it was probably a very big transition for you. You were used to having the higher levels of those hormones, and then switching to the gels, they either maybe they didn't give you enough, or your body needed to get used to those lower levels. Very severe, Janet. Where's the best place to get a DEXA scan if my insurance won't pay for it? You're just going to want to check with the different imaging facilities. So Sonora Quest, I'm not Sonora Quest, Smile, Simon Med, some of the other imaging facilities, and you want to compare prices. But even DEXA scan isn't terribly expensive. Do you recommend calcium supplements for building bone? I prefer calcium from dietary sources. Dark green leafy vegetables, dairy, if you eat dairy, sardines, with the bones. I prefer getting calcium from the diet if you can, but if you can't, if you just don't eat dairy, if you don't eat green vegetables or sardines, then calcium supplements if that's the only option. Cardiovascular system. That's why vitamin K2 is so important. So, of course, we take vitamin D3 to improve our absorption of calcium, but we need vitamin K2 to keep the calcium from entering our coronary arteries, to keep the calcium in our bones. We want to be sure to be taking vitamin K2. Do you suggest taking either synthetic or natural hormones? Yeah, natural for sure. I don't recommend synthetic. Oh, yeah. Nico, Rebecca, you're recording the presentation. If the birth control, if the breast cancer was estrogen positive, um, can cautiously, not that it can't be, but you're going to want to follow up closely, monitor your recording. So hopefully we'll have a copy. Taking the lowest amount of bioidentical. Oh, good. And experiencing another Melinda, experiencing quite a bit of breast discomfort. So you're going to need an adjustment. You're going to need an adjustment for that. So I don't know if you're taking progesterone. The progesterone can help alleviate that. A Trit, trit. I don't know what that means. And a cream for progesterone. So it's possible your estrogen may be too high, but your progesterone is not high enough. So it's a matter of balancing the doses, because that should be easy um, to take care of that breast discomfort. Estradiol patch is considered bioidentical, and the problem with it is that you can't control the doses. There's only a limited number of doses available, and so it can't be customized. Yeah, you can measure progesterone level in the blood, but it's not easy. It's not very reliable. Um, I do blood just because it's what's covered by the insurance companies. They don't cover the saliva or the urine testing. Um, you have to take those results with a grain of salt. So more about osteoporosis drugs. Uh, better than better than bisphosphonates. Breast cancer is the best. Receptor negative is best. So estrogen receptor negative. My gyno prescribed estradiol vaginal cream. Would that have any positive effect on? No, because the vaginal estrogens do not become systemic. They're only going to help locally in the vaginal area. Calcium D3, K2, and magnesium for bone. Oh, of course, definitely. Yes, yes. Take your calcium D3, K2, and magnesium along with BHRT. Yes. Uh, almost everything has calcium. Should you have levels checked? Yes, you want to check your baseline before starting BHRT and then monitoring them while you're on BHRT to make any adjustments in the doses. I think that was all the questions. I got through them all. We're still in within our hour.
All right, guys. So that was awesome. Thank you so much, Melinda. That was just wonderful. So much valuable information. Thank you all for joining us. We did record it, so as long as we have no technical difficulties, we will send out the link for you to watch this after the fact, as well as for anyone that unfortunately didn't get into the webinar before we started. So thank you all very much. Please look forward. In March, we're going to have another webinar that I will be hosting that one. It's going to be on bones, sleep, and stress, and how that all affects your nutrition profile as well. So have a wonderful day, everybody, and take care.